few powerful talks left. Our first is from Dr. Omolara Thomas Uwemedimo. Dr. Uwemedimo is the director of the Global Health Training Program at Cohen Children's Medical Center. Over her career, she has served as a consultant for maternal and newborn health initiatives in Africa. She conducted a 3-year study on the health and psychosocial needs of children with developmental disorder living with HIV/AIDS in Africa with the National Institutes of Health, and practiced pediatric medicine around the world in the Dominican Republic, Malawi, Nigeria, Cuba, and Kenya. Her training is extensive. She holds a bachelor's degree in biomedical sciences from the Sophie David School of Biomedical Education at the City University of New York. She received her medical degree from the New York University School of Medicine and completed her residency training in pediatrics at the Boston Medical Center and Children's Hospital Boston. She completed a research fellowship in health services research while completing a master's degree in population and family health at Columbia University Mailman School of Public Health. Please welcome Dr. Omolara Uwemedimo.
Thank you so much, Dr. Hill, for that kind introduction. My name is Dr. Omolara Thomas Uwemedimo, and I am an associate professor of pediatrics at Zucker School of Medicine at Hofstra Northwell and the CEO of Strong Children Wellness and Melanin Medicine and Motherhood. I have no conflicts to disclose. It was Christmas Day 2007, and I was rounding in the pediatrics ward at Kamuzu Central Hospital in Lilongwe, Malawi. After experiencing a rapid promotion from residency onto becoming a consulting pediatrician for all HIV-infected children at this large hospital in the capital, I was a little bit terrified. However, by the 4th month, I had a system for getting through the dozens of patients, but would always save Grace for last in this month rotation. I could spend more time with her and her aunt. Grace was 12 months old, newly 10 pounds, and had tried to leave this earth way too many times than I could count. On Christmas, I came to her empty cot and was terrified. I went to the lab and the radiology department, but then found her aunt sitting in a busy hallway, just with her head in her hands. I looked at her eyes. I knew Grace had left, and I tried to mutter some broken Chichewa to comfort her, but all that came out was silence and tears. It was at that moment I suddenly realized that I had been trained to practice a version of pediatrics that is safe and had failed Grace, a version of pediatrics where we keep children healthy within their circumstances. After Grace, I learned that when we fight to change children's circumstances, that is how we keep children healthy. That is socially responsive pediatrics. So I'm starting at COVID-19, not only because it's on our minds, but also because over 3/4 of the children who died from COVID-19 in this country are non-white. 2 out of every 5 kids live in poverty. The majority are Black, Latinx, and Indigenous. 1 out of every 4 children lives in an immigrant family. These are the children, like Grace, with the inability to change their circumstances, who look to their families. And then their families look to us, and they look to society. These are the families who we interact with every day, but we say that our role is only to give them health care. And then we don't realize that these are the things that our families are dealing with, that are top of mind when they enter our spaces. And when we just give them health care, our offices immediately become unsafe, because what we have done is made a choice not to push the system and use our privilege to respond. Now, over the past 6 months, we have all been given an opportunity to see how our circumstances can severely limit our choices. We are physicians who've lost loved ones, almost died ourselves, been laid off, filed for unemployment, had to close our practices. And we have the opportunity now to respond because it's not their problem. It's a problem that we've experienced firsthand. It hits close to home, and now it's our problem. So we have two roads. One, and I wonder if I'll get punished for this, but we can choose to stay comfortable. We can give recommendations like these to our families who encounter the issues that aren't on this sheet. And it keeps them marginalized and renders their problems invisible with no solutions. If we do this, if we don't share our stories, if we don't empathize, if we keep the wall up, our families are not willing to courageously share their experiences and their trauma. So we can continue to practice cultural competency. That's recognizing the impact of race and culture and aware of diversity, but it doesn't promote equity. It doesn't promote justice. And then we can move into structural competency and add on the impact of social needs and structural inequities, but it doesn't dismantle those structures or promote empowerment. I ask you to think about social responsiveness, where we're empowering, where we're elevating families' existing expertise and giving them the tools to navigate on their own what their solutions are, and disrupting false narratives by using our privilege to advocate against systemic oppression. So what is socially responsive pediatrics? Socially responsive pediatrics uses a justice-based lens. It moves beyond patient-centered and biomedicine. It helps to overcome structural and systemic oppression. It acknowledges future cultural beliefs, strengths, and historical trauma. It includes the family, the societal, and the community context that our patients live in. It promotes community-engaged approaches and also centers advocacy and empowerment at every level. So, when it comes to global health, there is no them, there's only us. Step one. My early career was founded on the fact that working in other countries allowed me to provide a solution for those countries that were experiencing inequity because it was so extreme. When I returned to the US, I noticed the same challenges, but also reflected on the opportunity that the solutions I use globally could be used right here for those that don't have the protections to have access to high quality care. And so those global health solutions are the solutions that we need for care of vulnerable children in the United States. And within that, we were able to create Global, which used the interest of residents and of faculty to work in global and immigrant health, and allowed for us to identify those solutions and apply them both internationally in places like Kenya and India, and locally, right here in Corona, Queens, New York, North Dakota with indigenous children, as well as in the Rio Grande Valley with partners taking care of recently migrated children across the border. And what we found was that our residents learned something called social responsiveness that we tried to train within them, helping them to clarify needs, helping them to set foundations for a collaborative working relationship with their families, identifying and discussing experiences, past experiences, and talking about the tough things like mistrust, like stigma and racism, and focusing on the immediate practical concerns to allow for movement into the deeper ones. It is easier to build strong children than repair broken men. And so in this, when we do that, we know that we have the opportunity to be able to impact children by impacting family, community, their daycares, their schools. Yet, a lot of times we don't do this in our practice. We solely focus on our patient and their healthcare in front of them. Many practices have over this decade moved into screening for social determinants of health and trying to get to those unmet social needs. However, what we found for marginalized families through our work has been that these practices, unfortunately, when we do that, we allow for parents to get frustrated. We allow for parents who don't have social capital to relegate themselves to not having their problem solved. Instead, we have the opportunity to think about how we can empower families. How do we provide more integrated approaches that allow for education and career coaching and job opportunities and financial support? And we miss the boat when we don't recognize families who are dealing with separation due to things like deportation and incarceration, families who are dealing with deteriorating schools and overcrowding, families who are dealing with residential segregation and police brutality. And so it's important that we realize how big this idea is and that we cannot do it alone. We need community partners, but physicians need to prioritize it and remember that when we prioritize it, we are not doing a favor, but we're improving our patients. So we took a step, myself and two of my brave partners, also Black female pediatricians, to decide and to relegate the fact that if we can't truly bring communities into clinics, doesn't it make sense for us to bring practices and physical health needs into community-based organizations? We would see. And so what we came up with was Strong Children Wellness, launched last year and started in the midst of COVID to integrate medical, social, and mental health services within community-based organizations in New York City, including the hardest hit COVID spots like Queens, New York. And what we've been able to do is allow for CBOs and physical health practices to sit side by side without hierarchy, knowing and valuing the mutual benefits that each other gives. And we've also created empowerment networks which include lawyers and a medical legal partnership, doulas, family navigators, family medicine providers, organizations like Lyft that provide coaching for parents and caregivers to help them increase savings and reduce debt and get careers that help them achieve economic stability. Literacy Partners, that is a two-generation approach to optimize literacy education for families. And Melanin Medicine and Motherhood, which ensures that providers are able, especially women health providers of color, are able to exist and work without the burnout and stress that they often feel, and allow them to provide the culturally affirming healthcare that they give and that patients deserve. Advocacy is our next, and our empowerment is our only way to true justice. And we can do that through journal articles. We can do that through features of our stories and sharing them. We can do that through Twitter and social media. We can also do it by ensuring that we speak up and speak out on the radio and media, and that we can stand up and go to the masses and stand at rallies and say things like families belong together and share the intimate stories that our patients have and bring those to light and humanize the people that we love, the people we care for, and the children whose families we're blessed to know. And then we can create networks to make sure that our colleagues are doing the work, to make sure that we recognize that we have a role in the anti-racist movement and that physicians have the privilege to help accelerate that. So it's time for us to stop accepting the things that we can't change and start changing the things that we cannot accept. I ask you, what have you accepted and what are you going to change? I ask for you to think about the 4 E's. I want you to engage. I want you to use the social environment as a key component for discussion with the family that fosters better engagement and openness. I want you to empower. I want you to provide a safe space for families to express their culture and for non-judgmental inclusion of their cultural nuances. I want you to establish networks of community resources that don't just give, but lift. And I want you to encourage action at every step. We can think, we can prepare, and we can research. But it is all for naught if it is not for action. And recognizing the system level barriers that only action and only demands will move us forward. So I stand here in privilege, not only as a pediatrician, but as a Black woman. And in many spaces, I am rendered silent. And if not silenced, I am made powerless. But like many Black women, I've had to reinvent that power that my freedom requires, as June Jordan has often said. So I stand here in my skin and use my skin to lift up the Black women who I hope that we can continue to lift up alongside all women and alongside our communities and our families and those who have died because of our silence on police brutality and maternal mortality. I am no longer afraid, Audre Lorde. So I stand here for Atatiana Taylor, for Sandra Bland, for Ayanna Jones, for Reagan Robinson and Shalone Irving and Shasia Washington, Amber Rose Isaac, and Breonna Taylor. Say her name and remember, Black girls like me do matter. Thank you for your attention.